Hello, my name is Jeremy Fisher, and on behalf of CME Outfitters, I'd like to welcome and thank you for joining us on the CMEO BriefCase series titled Keeping Pain at Bay, Strategies for Early Interventions and Safer Pain Management. In today's case, it's focused on the assessment and treatment and decision-making for Emmett, who's a 23-year-old hiker who injured his ankle while he was doing what he loves to do, hike. So a bit about myself. My name is Jeremy Fisher. Like I said before, I'm a physician assistant. I work for a staffing company called Team Health. I work in two different emergency departments in Central Ohio, one in Marysville and one in Circleville, Ohio. I've been a physician assistant since 2011. I have 2 years of family medicine experience and 7 years of emergency department experience. I'm also the lead physician assistant at those two facilities where I work. So let's start with an overview of our goals today for this activity. The first learning objective is to discuss strategies for integrating risk assessment into the discussion with our patients in an acute care or ED setting to uncover any potential risk for misuse and diversion of opioids using a validated tool. So we'll talk about how you can use a validated tool to risk stratify your patients and questions you can ask them to help you do that. And then our second learning objective is to review the evidence and guidance and recommendations supporting non-opioid pain management so you can apply those recommendations and treatment in your decision-making, and we'll go through that. So let's talk about musculoskeletal injuries. Of course, we know they're very common. They come up every day in my practice. So 65.8 million musculoskeletal injuries accounted for in 2010 and 2011. They represent 75% of injuries in acute care settings and account for a large amount of hospitalizations. So this is an important thing. These are things that we're doing every day. Dealing with people that have musculoskeletal injuries. So I'm curious, what percentage of your practice is devoted to musculoskeletal injuries? All right, thanks for your responses. A little bit about my practice. I definitely see a large percentage of musculoskeletal cases in the emergency department. I'd say for me, it's probably 65% of what I see. So it constitutes a large majority of what I'm dealing with. Of course, I'm dealing with people of all types, but musculoskeletal injuries are important to understand. So let's move on here to our patient case. So this is Emmett. He's a 23-year-old male that comes to the acute care clinic with an ankle injury that he sustained while he was hiking. He says that he lost his footing and stepped and rolled his ankle, which is a very common type of injury. He's got significant swelling and redness and pain, but he was able to hike back to his car and bring himself to the emergency department. And he says that he came directly to the emergency department or acute care setting right from the trail. He didn't go home. This isn't the next day. He came right straight to us. So at this point, what are you thinking in regards to Emmett? What additional information do you want to know at this point? One of the first things that we want to think about when we have a case like this is deciding whether or not we want to get an x-ray. And sometimes in some places there are nursing protocols where nurses and the triage nurse can order things before you see the patient. I know when we're busy, sometimes that's what happens, but it's important when you're talking to Emmett, when you're in there getting your history, to talk a little bit about how it happened. What was the mechanism of the injury? How did he roll his ankle? Did he roll it in or did he roll it out? And we know that as inversion and eversion type of injuries. And we know that if you have an inversion type of injury, usually you have pain on the outside of your ankle, on the lateral malleolus, but you're less likely to have a fracture. And then there's an eversion injury where your foot sort of rolls outward, which is more awkward. It usually happens when you step in a hole or some sort of really strange stress on the foot or ankle. And that's more likely to be fractured. And usually it's the medial side, the medial malleolus, that would be, we would be concerned about with that. So another thing that I do on my exam, I'll check and see, I'll push down on their heel, axial load, see if they have pain with that. Emmett was able to bear weight after this and get himself off of the hill, but sometimes after he sat for a while with no weight on the ankle, there may be more pain, more swelling, and he may not be as able to bear weight hours later or even minutes later after he's had weight off of his ankle. So you want to check that. And then another thing is direct contact injuries, which would would be something like a football player who's hit from the side, or a soccer player that has a strange stress on their foot or ankle. So I'll ask them if they have a previous history of an ankle injury, because of course, if you fractured any part of your ankle before and don't have any orthopedic plates, the chance of you doing that again would be higher. And then once again, is he able to bear weight? Is he able to take steps? So one of the things that we can use to help us with this, and this is a great tool, it's the Ottawa ankle rules that came out of Canada. And this is a really good way to decide if someone needs to have an x-ray. So just to review the Ottawa ankle rules, if you have tenderness over the posterior edge or distal 6 centimeters of the lateral malleolus, or the same thing on the medial malleolus, tenderness over the posterior edge or the distal 6 centimeters, that would require an x-ray, because you could have a fracture there. And then also inability to bear weight after the injury for 4 steps, which, in the emergency department, people are apprehensive about bearing weight anyway, but sometimes if you can get them up and have them try, you'd be surprised. Another thing that's part of the Ottawa ankle rules that's sort of in this graphic here, if you always want to, if someone's inverted their ankle, press on the proximal part of their 5th metatarsal, because they could have a Jones fracture or dancer's fracture from sort of rolling their foot under. And that's important to pick up, because that may constitute getting a foot x-ray as well as an ankle x-ray. And then also, they're navicular, which has a strange blood supply. So we always want to make sure that that's not fractured. And if they have any of that, you would want to get a ankle or foot x-ray. So let's go back to Emmett. So on his exam, when we examined him, he doesn't really have much tenderness on the medial or lateral malleolus on the distal 6 centimeters. He's not really tender anywhere on his foot, but he does have significant swelling. He was able to bear weight, maybe take a few steps for you. And so we'll say that he does not meet the Ottawa ankle rules for a x-ray, because it was an inversion injury. After talking to him, he rolled it in, an inversion injury. So those are less likely to be fractures. And then again, with the Ottawa ankle rules, he doesn't meet criteria for x-ray. Now we can start to employ some of our risk assessment strategies to try to figure out what sort of pain management we want to do for Emmett. So prior to our evaluation, you want to get a history and see what medications the patient's taking. That's very important. A lot of times the intake staff will do this for you, but it's also important to ask. I always try to ask people, what health problems do you have? Or do you have a health problem that you take medication for every day? Because sometimes I've run into this situation where people are under the impression that they don't have high blood pressure because they take blood pressure medication. And we know that's not the case, but they feel like it's corrected so they no longer have it, but they still carry the diagnosis of hypertension. So we have to know that. And there's a lot of things like that. You want to say, do you have atrial fibrillation, and are you on warfarin for that, or one of the factor 10 inhibitors, blood thinners, because that'll change your pain management strategy. Or have you had a heart attack and you're on clopidogrel for stents in your heart? That also is a situation where you may not want to use NSAIDs, because you shouldn't use NSAIDs in that situation. So it's important to ask these questions, and they may wonder, why are you asking about, my heart when I rolled my ankle? Well, it has to do with how you're going to go towards their pain management, right? So also, did they take any medication this morning? Did they take their pain medicine if they're prescribed it every day? Or have they missed a dose? Or did they take anything prior to coming into the emergency department? So did they roll their ankle and then take Tylenol or ibuprofen before they came in? Because if they did that, then it will change your strategy for them. Like if they've taken acetaminophen before they come in, you don't want to give them acetaminophen in the emergency department. You may want to give them ibuprofen or something else, and vice versa. So it's good to know if they've taken anything before they came in. And there are also tools that we can use in risk assessments that will help us make this decision. And so there's a multifocal decision making that you can do to try to make this decision and stratify the patient into a certain risk category. So looking here at this slide, you have this psychosocial approach. So you want to take the patient history and try to get an idea of their medical problems, and do they have chronic pain? Do they have maybe chronic back pain and they see pain management? Your physical examination. how severe is their injury. And we talked about the auto ankle rules. That's certainly part of your physical examination. Do they have an obvious deformity or something that is definitely a fracture? And also, you want to incorporate your diagnostic screening tools, like your prescription drug monitoring programs, to help you make those decisions. In Ohio, we have something called the ORS, which is it's a online prescription reporting service where I can go on and look and see what prescription someone has, who's written them, how many refills they have, how many tablets they were dispensed. So it can help me make a decision about pain management. I've had situations where people were on medications for opioid recovery and, maybe they're not honest with you or they forget to tell you that they're on that. And that definitely changes how you're going to manage their pain, especially if they have a fracture and you thought maybe you may put them on opiates. So with these tools, you can put people into a low risk, medium risk, or high risk category based off of their medical history, physical examination, and your diagnostic screening tools. Another thing that's very important is talking to patients about their prescription medication or recreational drug use. It's always a hard conversation to have with people to ask them about this. But I find that if you choose your wording carefully, and try to put the patients at ease, that a lot of times they'll tell you. It's important to make the patients understand that we're not the police. I think a lot of people have a perception that they'll get in trouble if they tell us that they take recreational or illegal drugs. That's not really the case. It's just that we want to know so that we can provide them the best possible medical care. So what I like to ask them is, in the past year, how many times have you used a recreational drug or prescription drug for a non-medical reason? And patients are going to be reluctant to tell you that they've used a prescription drug for a non-medical reason, but you can always ask. And once again, I like to use the term recreational drug because I think that it takes away the connotation and puts people at ease to tell you, oh yeah, here's what, I use this, I use that. So, and then you can use this tool to determine the risk level. So the opioid risk tool is really the main tool that we recommend. So let's go back to Emmett. So you discuss his recreational drug use, and he occasionally smokes cannabis. He has a few beers on the weekend, but he doesn't use any other recreational drugs or hard drugs. And he fills out one of these opioid risk tools, and his score places him in the low risk for addiction. And then after filling out the form, he tells you that he took citalopram for anxiety in college, but feels that he doesn't need it anymore. So that's another thing to consider is anxiety medications that someone may be on, whether it's something like citalopram or a benzodiazepine. They may forget to tell you that they were on it in the past. I think that we know that there's a anxiety component to pain. Some people are very anxious about being injured, which is totally normal. And they, in this situation, he may guard his ankle or not want you to examine it because he's anxious about having pain. So what treatment would you prescribe for Emmett? Okay, so let's talk about the best practices for acute pain management. And this is, there's multiple things we can talk about here. So one thing that's important is to use multimodal analgesics, different types of analgesics, to try to manage someone's pain. You have NSAIDs, acetaminophen, gabapentin, and immediate release opioids. And of course, we want to use immediate release opioids in the emergency department or any acute care setting. It's not really our place to prescribe extended release opioids. That's more of a pain management or family medicine or orthopedic. That's their realm. We're dealing with acute problems, right? So you want to also consider local or regional blocks. And this is something that comes up a lot when I have people with dental pain. If you have someone that has a broken tooth and they're having sort of a pounding, throbbing pain in their teeth, you can consider doing an apical block for them to try to give them some relief. And then also people with obvious fractures, you can consider doing a hematoma block. I've also run into orthopedic specialists that want us to put lidocaine patches over things like, greater trochanter fractures and things. So those are other types of pain management strategies to consider. And don't forget that those exist outside of oral or IV pain medications. And I think it's important to discuss with people under the cognitive strategies here that they will have pain. With something like this, with Emmett, with our case, he's going to have pain in his ankle. And we're going to do everything we can to help him with that and give him strategies to treat that. But you want to set up that expectation. Some people in the emergency department, I think, have the expectation that they won't have any pain after they've sought medical care. And they want you to help them achieve that through whatever means they see fit. And I think it's important to set up that expectation that you are going to have pain. This is probably going to hurt for a few weeks, especially in the case of this ankle sprain. You know, you want to explain the course of whatever the injury may be, explain what they can expect. And I think that sets people up to have a better expectation of the outcome. And, you know, there are other things that you can do to help with pain outside of medication, right? So, you know, things like, you know, like it says here, psychosocial resources like, you know, counseling, or, you know, if you have someone with chronic pain, that can certainly lead to depression. So those kinds of things are important. And then, you know, mindfulness, relaxation, aromatherapy, those kind of things have been shown to relax people, which goes back to the anxiety component of pain. And then under the physical strategies, you know, you definitely, if the person has a fracture, you want to immobilize it, use the correct kind of splint, you know, rest, ice, elevate. Chronic back pain can be treated with the TENS unit, but there are other types of pain you can treat with the TENS unit, you know, those kind of things, and also cryotherapy as well. So the Orthopedic Trauma Association has recommendations for pain and medication tapers following non-operative musculoskeletal injuries, which is here in this table. And this is a really good table because it kind of gives you a way of how to start. So if you have a minor injury, which would be like our example here, in the short term opioid, you can consider some tramadol, and if necessary, you know, something like you do hydrocodone as well, very briefly. And then a non-opioid would be NSAIDs as needed, or scheduled acetaminophen, 1,000 milligrams Q8. But if you have a major injury where someone has, you know, an obvious bone fracture or tendon rupture, things that are going to be more painful for longer, or have a longer course of recovery, you can consider hydrocodone as well, something a little bit stronger than non-opioid. You know, you can also consider ibuprofen and acetaminophen as well in that case. So this graph here we're looking at, this is the opioid versus non-opioid pain relief in post-operative pain. And so what's interesting about this is that, I mean, we hear about these studies a lot that they put acetaminophen and ibuprofen head-to-head with opiates, or they put ketorolac head-to-head with opiates, and it outperforms opiates in double-blind studies. And this is just an example of that. So this is the number of people needed to treat for one person to get 50% pain relief. So you can see with oxycodone 15 milligrams, which is not a low dose of oxycodone, 4.6 people. So that's almost 5 people you have to treat for one person to get 50% pain relief. As opposed to on the other side here, you have ibuprofen and acetaminophen is 1.6. So, you know, not even 2 people. So, and that's, I think, really eye-opening in that if you can have a double-blinded study perform like this, I mean, clearly, acetaminophen and ibuprofen do well for pain relief, and you can see that here. With multimodal analgesics, we talk most about acetaminophen and NSAIDs because they're available over the counter. So the benefits of this multimodal analgesia include you reduce the risk of side effects because you're using different types of medications as opposed to just one type of medication dosed over and over and over. And so that's important. So, you know, the side effects of acetaminophen, you know, that can liver damage, and, you know, you definitely don't want to take too much of that. And then with ibuprofen, they can be hard on the kidneys and ulcers. But if you can mix the two and use the two together, you alternate ibuprofen and acetaminophen every 4 hours, like I tell my patients, then you can reduce the side effect profile of either one of those medications individually. And so you're not really relying on a single class of medication. And I think this last point here is really important. It says not just over-the-counter medications. You're going to run into folks who have a perception that over-the-counter medications are less effective or somehow less powerful in some way than prescribed medications. But what I'd like to tell people is that over-the-counter medications are the safest, most effective, cheapest medications that are available. And that's why they're over the counter. They don't have to be managed by someone with a medical degree. I mean, you can read the directions. As long as you take them as directed, they're very effective. And so you just want to help people understand that because they may not have that perception. So for Patient education, ankle sprains for Emmett here, they're among the most common musculoskeletal injuries. Rarely do I have a shift in my emergency department where I do not see someone who has some type of ankle sprain. It's very rare. And prevention of musculoskeletal injuries like ankle sprains is important. So you want to make sure that Emmett is stretching and has, good strength. He's exercising. And perhaps if he was wearing hiking boots that were a little bit higher that protected his ankles, he may not have had an ankle sprain. And so you can discuss this with your patients, strengthening and stretching and things can help prevent pain in the future. And then also physical therapy and once again, that goes back to strengthening can help. And also flexibility can help with people that have a lot of ankle injuries. So now, what treatment would you prescribe for Emmett? So with Emmett, he is in an acute phase of pain. He's having a lot of pain in his ankle in the emergency department. He did come right into the emergency department after this happened. So you decide to give him tramadol 50 milligrams to break his severe pain. And that, we've been talking about over-the-counter medications and ways to manage a pain that are more conservative. But if you have someone in the emergency department that's having a lot of pain, maybe they need an x-ray, or you haven't, when you first examine them, they're having pain after the exam, it's okay to give them one dose of pain medication. I know sometimes I've run into providers that like to see someone having a fracture on an x-ray before they'll give them something like tramadol to relieve their pain. But in my own practice, I try not to withhold that. Just one dose in the emergency department, you're not going to create any problem with that if they're having a lot of pain. But, you can consider, we have it in quotations here, prescribed ibuprofen and acetaminophen, because you can write a prescription for ibuprofen. I rarely write for acetaminophen, but and that may be another strategy to help people take it, because they may feel somehow the prescription is better, and you can kind of get that vibe from your patients while you're with them. You can consider using crutches for short-term treatment. There's nothing wrong with giving someone crutches for the first 24, 48 hours with their ankle injury, but I always try to tell people to bear weight as soon as possible. There were some studies about this, that bearing weight on the ankle sooner rather than later, as long as it's not fractured, leads to better outcomes and shorter course. So I at least try to tell people, we'll give you the crutches, that's cool, but you need to try to toe touch weight bear, just with your toes, and then progress up from there and try to, lose the crutches after a few days if you can. Rest, ice, elevate. We can do things like an ACE wrap or like a Velcro splint. And those are fine to wear in the short term. And then you want to try to, for the first 24 to 48 hours, you don't want to be like running or doing anything that's going to put extra stress on the ankle. But, activities of daily living, like, getting up and making yourself meals and things like that, those are fine. In fact, you want to get up and do that. That'll help with pain. So if he's experiencing pain or instability after 2 weeks, that would be the time to follow up with primary care or orthopedics. It's difficult in the emergency department to assess for like a tendon or ligament injury, like if there's a torn deltoid ligament or something like that. It's difficult to assess in the short term because of the amount of swelling, which is, of course, the body's way of protecting the ankle. So after you've had some time, a couple weeks for the swelling to go down, and the patients can better assess if they have some weakness or instability. So let's summarize everything we did today with our SMART goals, which stand for specific, measurable, attainable, relevant, and timely. That is what I'm hoping that you'll take from this presentation to apply to your own practice. So you want to apply tools like the Ottawa ankle rules to determine the likelihood of an injury being a fracture and needing an x-ray, because we want to be judicious with x-rays. It's radiation, especially in children. So we want to make sure we're doing the right thing. If you decide that opiates are the best path forward, you want to use one of these risk assessment tools like the opioid risk tool and the prescription drug monitoring programs before prescribing, so you have a better idea of what's going on. And just try to remember that not all musculoskeletal injuries require opiates, or even surgical procedures don't always require opiates. And you want to make sure that you help people understand that expectation. And finally, just remember, when you're thinking about non-opioid pain management, over-the-counter NSAIDs and acetaminophen are good options. because they're multimodal. You can use them together, and they've been shown in a lot of studies to work well together. Then you want to have a pain management strategy that incorporates cognitive and physical strategies as well. So thank you for joining me today for the CMEO briefcase. Please visit the Opioid Education Hub, and you'll find other opioid and REMS activities, as well as a broad range of educational activities and resources for healthcare providers and patients. And I hope that reviewing this case of Emmett's ankle sprain today offered some tips and strategies that'll help you with your practice with musculoskeletal injuries. Thank you.